here, the red shirt towards the front. And then I've got another gentleman in the back in a blue shirt.
Excuse me.
And then we will come back.
Okay.
Great talk. In the face of uncertainty, do you ever flip it upside down and ask them what they are certain about?
Yeah, you can do that. You can do that. I think you can sort of say, how are things been working for you? I mean, I see you're coming into me and, you know, you listen to their expression and, you know, you try to sometimes make them aware of, sometimes the word workable versus unworkable comes to mind. And if people are doing something that's very repetitive in terms of their behavior, in terms of opioids or health seeking in some way, I mean, I wouldn't use those terms explicitly with the patient, but if you can highlight some of the things that they're doing repetitively in a sort of a fixed manner, I think you can say, you can sort of try to pry open some space with the patient maybe around, okay, so you think this, but what kind of result are you getting from that? And especially in terms of if you try to highlight, if you've already had a discussion about some of their values, I think you can kind of try to draw a contradiction there between the two. Does that make sense?
We got another gentleman in the back in the blue shirt.
Great talk, thanks. I'm captivated by your concept of this full expression of the pain. I haven't heard that before, but I really like it. And I'm glad you put up the acceptance and commitment there, because I can see the similarities. So when you're talking, when you're talking about full expression, I can see, both from a therapist perspective where we may be rushing to start alleviating the pain, or from the patient perspective where they might be rushing to alleviate the pain, and both those things prevent the full expression. So you said trying to avoid getting in the way of fully expressing it. Do you ever find you have to encourage the full expression? How does that work?
Yeah, I mean, I think what I try to do is let the patient know that I have their full attention. They have my full attention. That means I'm not writing notes, copious notes. I'm not sitting at my computer. I'm trying to position myself right in front of them, fairly close, whatever I feels like. You know, if I feel like they're moving away from me as I'm moving closer, I probably should back away. So I try to do some of these non-verbal behaviors. I try to control some of those in front of the patient as best as I can be aware of those. You know, I think it's a tricky thing. It's about, because I think you can lean in a little too hard on that too. I mean, I'm sort of using my idea in this talk is to push people to think this way, not necessarily the need to go all the way and take everything that I'm saying as the super literal. But so I think you can lean in a little too far, and that, I mean, most of our patients, medicine's over here, psychology's over here, the two shall never meet, and they expect that too. So if we lean in real hard and we start sounding that's something that they're not expecting, they're going to see that as a threat. They're going to start, light bulbs are going to go off that this is a threat to me in some way. So you got to be careful. You got to be subtle. Some people you don't have to be so subtle with. I think you have to use your judgment. You're going to make mistakes. I've made mistakes, so that's how I. Does that make sense?
We have a question up here in the front row, and then additional questions too. All right. I know you want to. And 1, 2, 3. Okay.
Thanks, Eric. I'll be quick. It's a two-part question. Fast.
Okay.
So how would you handle a patient who, in trying to navigate the conversation about how that patient is okay for right now, when that person has had the question answered by someone prior to seeing you, but you're not satisfied with the appraisal they were given, or the patient who was reassured but then rejected that reassurance by somebody else?
So the first question is, you may think that there's something else actually going on that sort of like there's underlying diagnosis that needs to be made, or?
I actually think the opposite, where they were given a diagnosis that wasn't helpful to progress.
Oh, yeah. Yeah, I mean, I think that's challenging sometimes. I think you subtly try to contradict the power of that diagnosis. I'm all about contradiction. I'm all about trying to pry open space, but sort of say, it really depends on what it is, whether I think where they're really fixed at. I mean, it's a little bit like a sparring match sometimes. You kind of move towards the idea of their diagnosis, and then you get a sense that they're acting a little bit like, kind of like getting a little angry with you, or you can sense that in their face, and I try to sort of say, okay, you know, we're going to back off that, maybe try to move to more of a safe area. But you try to get at that, and sometimes it takes a couple sessions. Sometimes you plant the idea early on, and you don't really go after it, but you just let them get to know you a little bit. I try to work somewhat softly in that department. And the second question was that they'd been given reassurance, but they didn't accept it. Yeah, I mean, I definitely have seen a lot of that, where it comes, I think you just try to be real with patients. Sometimes I tell patients, like, we don't treat pain really that well, and you haven't been treated well in the past. You know, whatever form, like, that makes sense. I mean, I try to modulate my reaction to them. I don't really say it like that, but I try to modulate it based on what I feel like might make sense to that patient based on some of my experience. But that's hard, you know. Sometimes it works, but at least you're trying. You're thinking that way. You're not thinking about that's the thing about these biomechanics and all this other stuff. That stuff clouds your head. You should be thinking about this other stuff. And if you're thinking about all this other stuff, it's just taking up, you know, your space, your workspace to really think well about this patient. So I think it's about that really more than always finding the right answer.
Hi there, Pam Holmes, and I'm seeing your fear avoidance questionnaire and those different assessment tools. Where would you fit that in with your assessment? Would you do that, you know, when they first come in, fill out papers, or do you establish rapport with them first? Or
sometimes I use that in the beginning. I don't use them all the time. I think that if you're a fan of using some sort of standardized assessment, you can look at some of that stuff, and sometimes that can be helpful for giving you some red flags on maybe some things. They're not perfect instruments. They don't capture everything, but I think there's stuff that's out there. And I would say generally in the beginning, use it as a conversation. So you might see how someone fills it out, and then you sort of say, well, I see how you filled this out. I'm not really trying to track that change. I really use that maybe as a tool to sort of say, here's what I see. Like, why don't you, as an opportunity to have a discussion, really. But usually in the beginning, before their first appointment with me, while they're waiting in the waiting room.
We got our next question over here. Could you put your hand up again, please? Or no? Okay. Right. This gentleman here was going to be our next then. Okay, yes, and she will be our last one.
Thank you for a good presentation, Eric. I have two small questions. First, fixed expression of pain. What is that?
Something that's like repetitive. It's lacking variability. Like we talk about variability of movement, I think there can be variabilities of expression. So if you look at someone and they're, you know, saying, oh, my pain's here, that's all it is all the time. Chances are it's more than that. And like I've had those patients that are just saying the same thing over and over again. Like I try to get some variability in that expression. So trying to stimulate metaphoric kind of conversations about it. I don't say like, well, now we're going to have a metaphoric conversation. You know, I just sort of say, like, what is your pain like? You know, try to ask what it's like, as opposed to sort of saying, tell me the number of your pain. Where's your pain at? And what happens when you have that pain? And just sort of let them fill in.
Thank you. Also, you talk about the patient's full expression of their pain.
Right.
Are you worried that, I think I would like an elaboration how you do this, because a full expression of pain, wouldn't that frame the patient to feel his pain? And we know that just talking about pain activates the neurotract for pain. So could we possibly create pain from trying to express their full experience?
That's a really good question. So my underlying assumption is it's really difficult to separate. I can say anecdotally, I think most people in the room, if they think about the pain experiences they've had, they experience pain, they don't express it, and there's times when they express it and they don't experience it, and that exists, that difference. But we can't. I don't know how we really measure that. I mean, most of the brain scans is someone saying they're in pain, and we look at the brain at the same time. So, you know, are we looking at their expression of pain, or are we looking at their pain because they're expressing it at the same time we're scanning their brain? I know there's some stuff that people are trying to make some work in that department. But I think that's somewhat challenging. I think the full expression of pain is, I might be getting away from your question, so but is sort of an idea to push you as a clinician to ask for a little bit more. It's sort of conceptual. It's not right 100%. There is no magical full 100% of expression. It's just trying to get more. And to answer your question now that just came back to me is, when you do give people attention, they're going to express more pain to you. It's going to happen. If you have the attention for it, it's going to happen more. But that's not the problem. I think we think about that as being the problem. That's actually great. I think it allows us to move past that stage in the sequence. And I really look at it as a stage sequence. So if you allow it to happen, then we get the opportunity to move past it. And I think that's the problem, in my opinion, that we're not allowing that to happen enough. But yeah, it's sort of paradoxical, and it doesn't always jive well with the research if we're saying, the researcher wants to alleviate pain, alleviate the expression of pain, but then, we're showing that if we give people attention, they express it more. It's confusing for some people to interpret.
We have one last one over here. I see a couple more hands that have popped up. Please write those questions down and put those in the question boxes by the exit doors. And then there will be an opportunity for Eric to hopefully pick your questions.
Thanks, Eric. That was fantastic. You touched on this idea of an area where we blend between manual therapy and psychology, and I think that's a really important area. I'm really I feel really strongly that provided we stay within our scope and we're just limiting ourselves predominantly to pain, that it's an area that manual therapists can have a really big impact. Sorry, is that working? Mm-hmm. And I think because we have those long consults and the potential for really good rapport, that we're really well placed to be implementing this stuff, again, provided we stay within our scope. How would you suggest that manual therapists upskill in these areas like CBT and ACT? What resources and courses would you suggest?
Yeah, well, I think that a lot of the work hasn't been done so much. There's a lot of resources, and I think you can seek these out. You can try to cross over and take a class in CBT, especially as it pertains to pain, or take ACT training. But it's not always going to make sense for us to do it exactly how psychologists do it. And I think we have to sort of take what makes sense, because, like you said, this merger between the two, it's going to look a little bit different, but that's because we get to do so much more than psychologists do. And I think that's really the power that we have. But I think we have to move more towards them than they can move towards us, because they've got other things. I don't want to treat depression or bipolar, all that stuff. I don't want to be that. But I think we have to learn how to have a conversation about values, and we have to really be comfortable with emotion existing in the treatment context. I think those are the two big things. And I think psychology is as confusing as the rehab sciences in terms of techniques and disciplines. I really like behaviorism, I really like ACT therapy, I really like motivational interviewing. These are some things I've sort of gravitated towards and found some inspiration from, but I'm not saying that that's an exclusive or an exhaustive list. And I'm in school, so maybe I'll have an answer in a couple of years too.
Eric Kruger, everyone.
Thank you.